Good evening, everyone. Welcome to the 19th edition of our Ocular Genetics Interest Group. Today, we have two clinical genetic correlation cases presented by Dr. Mitali and Dr. Priyanka. Their topics are unraveling the overlap and from ocular findings to systemic insight, PHARC syndrome. So, the second presentation will be by Dr. Mitali. She's a Pediatric Ophthalmology Fellow at Dr. Shroff Charity Eye Hospital. She's done her DNB in ophthalmology from Northern Railway Central Hospital in New Delhi. And she's done her IOL Fellowship from DDI Institute and LASIK Vision Center in Kota. This session will be moderated by Dr. Shailja, who's a senior consultant in Department of Pediatric Ophthalmology and Ocular Genetics at Shroff. The first presentation will be by Dr. Priyanka. She's a Vitreoretina Fellow at Dr. Shroff. She's done her MS in ophthalmology from DI Patil Medical College and Research Center, and she's done her ROP training from LB Prasad Eye Institute. Her session will be moderated by Dr. Shalini. She's a senior consultant in Department of Vitreoretina in Dr. Shroff Charity Eye Hospital. I extend a warm welcome to both the speakers and both the moderators.
Thank you, Nivedita.
Thank you, Nivedita. Yeah, Priyanka, please start sharing the screen.
Okay, ma'am.
Both the cases today are related to retinal dystrophy and with some systemic findings. So, looking forward for an interactive discussion.
So is my slide visible?
Yes.
Okay. Okay, so good evening, everybody. Now, the topic of my presentation is from ocular findings to systemic insight under moderation of Dr. Shalini Singh ma'am, Nivedita Rathore, and Riya Ratna. So we start with the case discussion where the 29 years old male presented with complaints of difficulty seeing in the dark since 7 months. There was no similar history in family, but there was a history of both-sided hearing loss since 4 years, history of right ear surgery 4 years back, and history of both eyes cataract surgery 12 years back. Now, on ocular examination, the best corrected visual acuity in the right eye was 6.6 partial N6 and 6.12 partial N8 in the left eye. The lens status is pseudophakic in both the eyes with the given refraction. Now fundus image, now center I have put the normal fundus image, and if we compare this fundus image with patient's fundus images, you can see the RP mottling at the posterior pole with slightly pale disc and peripapillary atrophy, which is more in the left eye, and attenuation of vessels, suggestive of retinitis pigmentosa sine pigmento. So the fundus autofluorescence, the central image is the normal autofluorescence image of the fundus where the disc with retinal vessels and the center of the macula, it is hypoautofluorescent. So when we compare with the patient size, we see the hypoautofluorescent flex, which is corresponding to the flex region. Then we see the central hypoautofluorescence surrounded by hyperautofluorescence, which is suggestive of Robson-Holder's sign. The OCT picture of both the eyes shows very subtle RPE changes and the normal reflectivity of all the retinal layers with the normal foveal counter. Now what we have in our hand, it is the patient of retinitis pigmentosa having the history of hearing loss and had history of cataract in both the eyes. So what are the DDs will comes in the mind? That is first is the most common Usher syndrome, then Refson syndrome and the PHARC syndrome. So we prescribe the glasses for the patient and we ask him for the genetic counseling and the family screening. So this is the pedigree chart of the patient, where is the patient only proband in his family with the retinitis pigmentosa, hearing loss and cataract history. So what is Usher syndrome? It has three types. Type 1, it is congenital severe to profound deafness and vestibular areflexia, the onset of RP within the first decade of life. Whereas in type 2, it is a congenital moderate to severe hearing loss with the normal vestibular function and onset of RP within second decade of life. Where in type 3, there is a hearing loss, vestibular dysfunction, and onset of RP could be more progressive, sporadic, variable, respectively. So Refsum syndrome, it is more of a metabolic disorder, and it is caused due to the accumulation of phytanic acid. It involves skin, shorten the fingers and toes, loss of smell will be there, retinitis pigmentosa, hearing loss, and cardiac arrhythmia. These are the features. So we did the whole exome test and we found that the patient was having PHARC syndrome with the mutation of ABHD12. So the below picture, it is the just for an example for the better understanding where the what happened in mRNA that the three nucleotides comes together to form a protein block. But in this patient, what happened? At chromosome 20, at this position, there is a duplication of a nucleotide, which caused a frame shift for the further nucleotide and protein blocks, which got stop codon. So it is a homozygous zygosity, and the autosomal recessive disease and likely pathogenic. So we again went back and we did the CNS examination of the patient, but patient was not giving any history of tingling, sensation, numbness in his limbs. But when we conducted the nerve conduction velocity test, it showed the demyelinating motor sensory polyneuropathy involving bilateral upper and lower limbs. So we found his ENT papers also, and it showed the bilateral severe hearing loss, for which he had undergone right-sided cochlear implantation in 2021. Now come to the case number 2. The 28 years old male presented with complaint of difficulty in the night vision in both the eyes since 1 year. There was no similar history in family, no history of hearing loss, weakness in limbs, and tingling sensation in limbs. But there was a history of trauma to left eye in childhood. So the left eye is non-perceptive to light, so as it is a thumbsical eye, but in the right eye, the vision was 6, 18, and 10. Unfortunately, we couldn't get the fundus images, but it has the typical features of retinitis pigmentosa in both the eyes. So we did whole exome test. Again, the patient...
Left eye, we were not able to see the fundus, Priyanka.
Yes, sorry, ma'am. In the right eye, it was a retinitis pigmentosa. So we did the whole exome test, and again there was a mutation of ABHD12, and that this time there was a deletion of G and homozygous. It is recessive and likely pathogenic. So coming to the discussion, the PHARC syndrome, it includes polyneuropathy, hearing loss, ataxia, retinitis pigmentosa, and cataract. It is autosomal recessive syndrome, and it is a slowly progressive neurodegenerative disorder. So it is a biallelic mutation in ABHD12. It could be homozygous mutation or compound heterozygous. So what happens because of the mutation in the ABHD12, there is an accumulation of oxidized phosphatidylserine, and it causes pro-inflammatory cytokines accumulation, and that leads to the neuroinflammation, mast cell degranulation, and lymphocyte proliferation, ultimately leads to cell death. Now, in this paper published in 2010 by Fisker, Strand et al., they found that the microglial cell has mostly expressed in ABHD12, and that's why it is included. It involves the neurodegenerative disorder and retinal dystrophies. So what are the clinical features? It includes polyneuropathy, sensory neural hearing loss, cerebellar ataxia with cerebellar atrophy, retinitis pigmentosa, and cataract. So this is a paper published in 2024. So far, only 60 to 68 patients were reported. And out of them, the study included 58 patients with PHARC syndrome from 37 different families with 27 known ABHD12 mutation. So the incidence would be 1 in 1 lakh worldwide. Only 20 patients showed all main features and the mean age was 11 years. So in their overview, they found the C337 was the most common mutation. So out of 58 patients, the 91% had polyneuropathy who underwent the CNS examination, and likewise the 84% were positive for retinitis pigmentosa, 86% cataract, hearing loss, and 71% cerebellar ataxia. So peculiarity of the first case was the duplication of the mutation, duplication of A, because in this overview, which is published in 2024, there was only one case where the duplication occurred. The second one is the asymptomatic polyneuropathy. The patient was asymptomatic for the CNS complaints, but when we did the nerve conduction test, it was positive for the polyneuropathy and retinitis pigmentosa, cine pigmento variant. So management would be the systemic examination, including CNS, ENT, and ocular examination. It is important. The imaging is also important. The genetic counseling, the understanding of the syndrome, and the family screening, and the importance of all these things we should counsel the patient and the patient's relative also. The treatment options, the vitamin A supplementation, gene therapy, stem cell therapy, and retinal implant. Now, given the size of primary transcript of ABHD12 likely fits into AA vector. So, this could be the potential candidate for gene augmentation therapy. So, these are the low vision aids we can use for the patient. And the key points are the PHARC syndrome is a rare phenotypically heterogeneous syndrome, involves multiple systems. So it should be in the differential diagnosis of the patient retinitis pigmentosa and hearing loss. The patient should get full clinical workup, including neurological, ophthalmological, and audiological test. Early recognition is also important, and the management is supportive, rehabilitative, focusing on preserving vision, hearing, and mobility. Thank you.
So thank you, Priyanka. Like one of the big highlight of your case was that the sensorineuring, the neurological signs and symptoms were discovered after we went back and phenotypically traced that thing. So the patient was asymptomatic, but like it is highlighted in this case, we should keep in mind and look for all phenotypes. We can always reverse see and look for all these symptoms.
Yes, ma'am.
Yeah, thank you, Priyanka, for this very rare case and presenting in front of us. So PHARC syndrome, the most commonly whenever we see, hearing loss with retinitis pigmentosa, it's ushers that comes to the mind because that's the most common, followed by refsums. So, and cataract is also quite common in RP patients. So you might think that this is probably, a part of, retinitis pigmentosa only when they develop cataracts. But PHARC syndrome is like a very rare phenotype which needs to be kept in mind. In fact, I also came to know about this when you guys presented this case. So I don't know whether others in this group have seen PHARC syndrome before. I can see Deepika here. Deepika, have you seen PHARC syndrome before?
Hi, Dr. Shailja. Very nice
Hi.
case. I have not seen. Thank you for sharing such a rare case. Yeah, I have
Yeah.
not seen. Yeah, thank you.
Yeah, so I think the cataract also comes much earlier than the other RP cases. That could be borne in mind if there's cataract also and there is a hearing loss. Because in ushers, is it that common? I don't think so. I've seen a lot of cataracts in Usher syndrome. I mean, early onset cataract. Dr. Shalini?
So, yeah, you're right, Shailja. Ushers may we see it a little later when the
Later.
retinitis pigmentosa is full blown. Then we might
Yes.
see cataract.
Yeah, so if we see, that's the hint for us that as an ophthalmologist, if we see a hearing loss along with RP and an early onset cataract, you should keep PHARC in mind. And the next things need to be seen is, I think, just the vestibular and the the neurological, right? The polyneuropathy part, which needs to be examined. And as you had shown that the polyneuropathy was like a subclinical polyneuropathy here. Patient was not having a symptom, any symptom at this point,
No,
right?
ma'am.
Only on NCV you found it. So there might be implications for his, hand and feet function and their sensations later on. So getting them in touch with a neurologist would be a good thing,
Yes.
such patients.
When I was speaking to the patient, I felt like his speech was a little abnormal. So I think he
Okay.
had dysarthria, but like I just noted it and didn't really think much about it. But when the diagnosis came back and like in retrospect, I think he is starting to show some signs of his polyneuropathy. And these things
Oh, okay.
come up when you like have a longer conversation with a patient in a clinic and you're sitting.
Oh, yeah. Yeah, so many a times it happens, we tend to do this reverse phenotyping because in the busy clinic, you just think about the common things and assume that this is probably, what we have it in our mind. So as I said, no, my first thing would have come would be ushers. I would have even written on the notes that this is
Yeah.
ushers, and then it hits you when the some other alternative diagnosis shows up on the genetic testing.
Yeah.
So again, coming down to the same thing that we reiterate every webinar is that a deep phenotyping or a complete evaluation, comprehensive, not just eye, but other systems also is quite important for these patients. Any other person wants to add anything? People from among the attendees, any other question or comment?
Hi, Shailja. Tanmay here.
Hi, Tanmay. Yeah.
Yeah, so I myself have not seen refsims before, but when I was in Belgium with Professor Bart, he highlighted a case. So there was a similar patient of RP with deafness. So
Okay.
he said he just initially the routine workup was going on, but then one day he just saw his toes, and the
Mm,
big toe was shorter than the others. So then he
mm,
said this could be adult refsums. So it's very important to look at the person, a patient
mm.
as a whole. Especially now we tend to look at the fingers, but the toes, shoes निकाल के देखो ये होता नहीं है
Yeah, yeah,
कभी.
yeah. Yep, yep.
Because adults refsums, it is treatable. The systemic features are treatable.
Yeah,
The
yeah,
metabolic thing. So it's very important to check the whole look beyond the eye and do a thorough, at least external
yeah.
phenotype from our side.
Yeah, so I think that's another take home that if there is a patient of RP with deafness, look at the toes.
Hmm.
So because that is something which is treatable, and also the skin for ichthyosis, there's
Yes.
something which is treatable. So yeah, point well taken, Ranmay. Yeah, thank you.
Dr. Shailaja, if I may ask just a question only,
Yep.
based on the like Dr. Priyanka or Dr. Shalini, like if you can give us some thoughts from the literature which had the highest number of published cases of this PHARC syndrome. What was the age of onset of this polyneuropathy symptoms? And what was the most common type of cataract which was seen?
Ma'am, polyneuropathy, the ranging, the age is the childhood to 53 years. The mean age is the 23 years for polyneuropathy. And most common cataract found in this cases was the posterior subcapsular cataract.
Okay, thank you. So it has a wide range, the polyneuropathy. So I
Mm,
think there is a chance that we can miss it definitely in the clinic.
yeah,
Yeah. Very nice case. Thank you. Thank you.
thank you. So if there are no other comments, then probably we can move on to the second case,
I have
Nivedita.
one more thing to add.
Yeah, yeah, please.
In this case, when you look at the pedigree, it's a homozygous mutation, autosomal recessive condition. Parents are non-consanguineously married. So usually in these conditions, we would think that the risk of recurrence is very low. Very low, and like if they want to rule out completely, we can offer carrier screening to the other partner. Retrospectively, when they came to the OPD, I asked them if they are married within like the same community or something. So then they told that both their parents were from like nearby location only, And then I asked him, is he married? He is married, he has children. And I asked him, is he married within that location? So he said, yes, very close by. So that really increases the chance of the partner also being a carrier for this condition, and then the risk of recurrence completely changes. So in this situation, I think we should I told them we should get carrier screening for the wife to know the risk of recurrence. In this case, I think their family planning was complete. So I
Yeah, they already
think
have two kids. Yeah.
so I told them wife can get tested, but this is how you could miss carriers if they're non-consanguineously married. But in our country, we will see a lot of endogamous marriage.
Yeah. Yeah, agreed. And what about the kids? Are they having any symptoms as of now? And how old are they?
Mm. Dr. Priyanka, can you show the pedigree once?
Yes, yes.
I know they
They,
don't have any symptoms, no cataract or
as
anything.
of now, but yes, he himself is how old? He's himself 29, 30, right?
Yes, and he had cataract pretty early on.
Yeah. So the kids would be, matlab, not be so old. So maybe they may develop. You never know.
Yes.
What was the age of onset of RP in him? 1 year, 2 year? The night blindness symptoms?
RP was 1 or 2 years.
Yes.
Since 1 or 2 years, no, Dr. Shalini?
Yeah, 2 years.
Yeah. So cataract came first, in fact, before the RP.
Yes,
Yes.
and
Yeah,
he
before the
already
Yes,
was
RP.
yeah,
also
he
came
came to us with cataract surgery. Hmm.
Yeah, already cataract surgery done. And hearing loss was also there. And then the night blindness came later.
Hmm.
Yeah. So maybe those symptoms should be asked to the patient, the kids. Maybe they have hearing loss. If
Yes.
you ask them directly a vision loss, maybe you may miss. So all the spectrum, entire thing has to be asked them if you really want to know whether they have it
Hmm.
or not. And may develop later also, you never know. If the mother is a carrier, all these things are there.
Hmm.
Yeah, good. So maybe in follow up, we can ask them to, come. Have the kids come, or they have just told that they are not involved. It's like
Hmm.
the parents' history.
Yeah, we have not seen the kids.
Yeah, so maybe they should be
Hmm.
asked to, bring them once and we can see them.
Hmm. We can do that. We shall do that actually.
Yeah. Okay, great. So let's move on to the next case, Nivedita.
Yes. Dr. Mitali.
Hi, good evening, everyone. Hi, are my slides visible?
No, Dr. Mitali.
Not yet. It's screen sharing has started. Yeah, now we can see.
Good evening, everyone. I am doing a case presentation. This is an 11-year-old baby, Sarita. She presented to the OPD with chief complaints of shaking of eyeballs since 4-5 months of age and diminution of vision since 4 years. The birth and developmental history was normal. Medically, she had pneumonia 4 years back. There was no history of blindness or low vision in the family. As we can see on ocular examination, she has enophthalmos both eyes. The best corrected visual acuity was PL positive, PR accurate. She had mild hyperopia as her refractive error. The extraocular motility was full except for mild seesaw nystagmus. The pupils were sluggish reacting in both the eyes. The anterior segment was normal. She had no systemic abnormality. We don't have the exact picture, but this is a fundus reference picture. As we can see, she had a mild optic disc pallor with attenuations of vessel and RPA modeling. On the basis of enophthalmos, fundus picture, amaurotic pupil, and hyperopia, there were three differential diagnoses that came to our mind. One was the LCA spectrum, the second was early onset retinitis pigmentosa, and third, it is an umbrella term which is generally used for inherited retinal dystrophies, that is early onset severe retinal dystrophy or severe early childhood onset retinal dystrophy. If we think on the terms of LCA, it is present from birth or infancy. The vision loss is severe and profound. It comes early. Nystagmus is there. The fundus appearance is variable. which may be normal in the early stages. The main highlight feature of LCA is the ERG findings, where it is extinguished. It is mostly an autosomal recessive disorder. It is stationary or slowly progressive. In few cases, CNS manifestations like intellect decline and metabolic problems like auditory problems have been reported. Secondly, if we think on the lines of early onset RP, the presentation is variable in childhood. The main key feature is night blindness or peripheral loss of vision. The nystagmus is variable. On fundus appearance, we typically find bony spicules and pigmentary changes. The ERG shows reduced findings, more in rods and cones. It has multiple inheritance like autosomal recessive, autosomal dominant, and X-linked recessive. As we know, it is a progressive condition and it is rarely associated with syndromic forms. If we think of the third diagnosis, the early onset severe retinal dystrophy, it begins before age of 5 years. Since it is a combination of these two, the vision loss could be central, peripheral. Nystagmus is there. The fundus may be normal at birth and the pigment accumulates later. The ERG findings are markedly reduced and it is an overlap of LC and RP genes. It is a progressive condition. So we did the pedigree analysis for the child. As we can see, the proband, it is a 10-year-old kid. The birth and developmental and the prenatal history is uneventful. The child goes to school and she is in grade 3. She has a normal intellect. There is no history of hearing loss and no history of seizures. At this stage, we want to know the pedigree because we want to know what is the prognosis for the child, the treatment possibility. As if you're thinking on the LCA spectrum, there are multiple genes out of which RP65, there is gene replacement therapy which is going on, and we also want to know the recurrent risk. So, but the genetic report turned out to be an ALMS1 gene mutation on exon 6. So, what is ALMS1 gene? It is a protein involved in process such as microtubule organization, cilium formation and maintenance, extracellular matrix production, cell migration, intracellular transport, and cell cycle regulation. Then we have a variant that is C1276 deletion. It is a homozygous single base pair deletion in exon 6 of the ALMS1 gene that results in frame shift and premature truncation of the protein 4 amino acid down to codon 426. It is an autosomal recessive and a likely pathogenic variant. So, what do we know of the variants? Most of the variants are pathogenic. That means the variant is confirmed to cause the disease and it is consistently associated with the phenotype. Likely pathogenic means there's a high probability of disease being caused, though not definitive. Then there is variant of uncertain significant. It lies between pathogenic and benign. And then we have likely benign, that is, it probably does not cause a disease and low clinical impact has been expected. And in benign, the variant never causes the disease. It is generally seen in normal individuals. Let's have a recap of what Alstrom syndrome is. It is a rare autosomal recessive disorder caused in the ALMS1 gene. Approximately 120 cases have been reported in UK as of now. It begins in infancy with progressive multi-organ pathology. So it has cone rod dystrophy, which causes early visual loss and blindness by the second decade. There is sensorineural hearing loss. They also have childhood truncal obesity with insulin resistance and type 2 diabetes mellitus, dilated cardiomyopathy, which is the leading cause of mortality, and multiple systemic manifestations of liver, kidney, and lungs. The main thing is the child has short stature and endocrinal abnormalities. This is a reference fundus photo picture of an Alstrom syndrome. We can see mild optic atrophy, the attenuated blood vessels, and RP changes, which are more prominent on the fundus autofluorescence. These are the systemic manifestations like truncal obesity, short stature, dilated cardiomyopathy, and the child also has acanthosis nigrans. So, if we think of what we have seen till now, the child ophthalmologically, the phenotype was suspected to be an LCA spectrum. but the report suggested of an Alstrom syndrome. But we have also seen that Alstrom syndrome presents with systemic manifestation, but our child does not have systemic manifestations as of now. So we did a literature review, and these are the multiple systemic associated features. We have to see that the variation of all these things is variable. Like road cone dystrophy is present from birth till 15 months of age, while if we see the kidney and the kidney diseases, it presents from adolescent to adulthood. Similar is with the other disorders. So, due to varied age at presentation, we cannot rule out Alstrom syndrome in this child. Then we also need to know one more thing, that the ALMS1 gene, it is a large genome with pathogenic variant clustered around 8, 10, and 16, which typically causes the protein truncation. Our case had the variation in exon 6. Atypical mutations have also been reported outside these hotspots, as in exon 5 and 20. They result in a milder or a variant phenotype. Such cases can be missed by targeted testing of common exomes, highlighting the need of complete ALMS1 sequence. The main is exome 8, which are particularly linked to delayed or mild renal involvement in Alstrom syndrome. This kid had mutation in exome 6, which could be a milder variant or a new pathogenic variant. There was another study done in Indian population. They did the whole genome sequencing. They also had a similar case of LCA at the age of 2 months and 6 years, which had similar family, which do not have any family history, but the findings were similar to our case. They have followed the child till 16 and 19 years of age. These two children still do not have any systemic manifestation, but they have proved to be an ALMS1 gene positive. So, this case highlighted that ALMS1 mutation can present as isolated retinal dystrophy, reinforcing the need to include ALMS1 in genetic testing panels for the LCA patients. Out of all of this, when our patient asked, you were thinking about LCA, the report came out to be Alstrom syndrome. What do they go back to? We need to make the patient understand that this is a stationary disease in terms of ophthalmologic manifestation, but the child may develop systemic manifestations in the long term. The child will go back home with a unique disability card. We can advise them for a special school educator and a periodic systemic evaluation. This is a University of Iowa inherited retinal disorder form. So, as the studies are going on, the retinal pathology can often be the first manifestation of a multisystem disorder. So, anytime we see a child with an inherited retinal dystrophy, we need to ask what is the age of onset, what was the earliest symptom seen, what are multiple diagnoses that have been previously made, and if you're thinking of a selective rod cone or a cone rod, we need to ask the daily movement of the child, as in, is he comfortable in the bright light or dim light? If he gets up at night, is he able to walk to the washroom, or does he need some dim light to do that? If he goes out, is he okay with the bright light, or he uses a sunglass or a cap for that? We also need to rule out, see for the syndromic features in the child from top to bottom. That is deafness. The child has polydactyly, obesity, diabetes, abnormal cognition, developmental delay, seizures, ataxia, hypertension, heart disease, malformations. And we also need to see if the child is on any current chronic medication, which could also be an added factor for decrease in vision. Does the patient have any history of cancer or autoimmune disease? Any relevant family history? And if the child is mobile, is he driving or not? And we can also do a color testing in these children. Thank you.
Thank you, Mitali.
Thank you,
Yeah,
ma'am.
so yeah. So this form is for overall retinal dystrophy, not just for pediatric onset. That's why the driving and other history is also there. It's a very useful form. One can use it directly or modify it as per. But I think your case and the previous case both have highlighted the importance of systemic history and a systemic diagnosis full evaluation in patients. Uh, the second case definitely shows the variety or the unique, genotype phenotype correlations which are seen in our population, which is often quite different from what is published in literature. Many a times we come across, genetic variations where we fail to match it to whatever is published in the literature, and then we keep thinking of whether the lab has done something wrong, or what went wrong and why is it not fitting. But quite often it is just a phenotypic variation which is seen, probably maybe unique to Indian population. Like you saw, there were two other cases which an exon 8 mutation, which were again not showing any systemic association of Alstrom's in Alstrom. So despite with you can't just refute the diagnosis altogether and tell to the patient that you may not have Alstrom. At the same time, you also have to have a caution when such reports come, and declaring a patient with a systemic or a syndromic disease in the absence of manifestations at presentation, because we don't know whether she will develop a full spectrum of Alstrom, or whether she may remain without any systemic disease altogether her entire life. So very careful post test counseling is very important here, that you have to slowly give them the information and not totally panic the patient or the parents. So it was a very good learning case for me also, and I'm sure it's useful for others also. That not every time, I mean, when there is, what do you tell the patient? Alstrom is there, but child does not have any Alstrom. Do we refute it totally? But when we looked at the literature, we saw that yes, there are so many phenotypic variabilities in Alstrom patients, and based on the exon, exon involved can have this, um, phenotypic variability. So we are just trying to find out with time whether this exon 6 proves to be a milder variant of Alstrom. It will be good to report this so that it's there for other people to find out. But it will be also good to follow up the patient and see how she turns up in future.
Yes, ma'am.
But now her management is basically just helping them get a UDID card, and maybe rehabilitating her with um, a smart vision glass or some other vocational training, because her vision is very poor. So any other thoughts or comments?
I'll just add a comment. Hi. That absolutely, like there are this phenomena is called pleiotropy, in which within one gene there could be a syndromic association or isolated findings as well. So not completely relying on the genetics report in that sense. I mean, it is a likely pathogenic variant for this patient, and there wasn't much reason to question it when it comes out, and hence it
Mm,
is easy to just very quickly call it Alstrom syndrome. And the lab has all the reasons to report it as LP also. So the classification is not wrong per se, but going back to the literature and then looking at how it might manifest, which you have already pointed out, becomes very important. And this phenomena has been seen in a lot of other eye disorders also, like in OPA1 also. It could be just optic atrophy, or sometimes some neurological signs can also be there. Or like depending on the type of variant in CYP1B1, it could be isolated glaucoma, or it could be other manifestations in the eye also. So one always has to keep this in mind.
yeah. Yeah, agreed. Had this been a VUS, then it would have been even more difficult for us to
Yes.
counsel the patient. Yeah, because
Mm,
it was likely pathogenic. We were much sure, and right now our thoughts are going in that direction. But let's see how this
yeah.
patient, has the
Grows up.
finding and the follow up.
Yes.
Yeah, as she grows up.
Yes. Yes.
Yeah,
Hi, Dr. Shailaja. I would like
yeah,
to
right,
add
Deepika.
something.
Yeah, please.
Thank you, Dr. Mitali, for the overview of Alstrom. It was very nice. Uh, I had this doubt on the location of the mutation in exon. Ria or like Dr. Shailaja, if you all know anything on, because if you see the mutation over here, it's very early in the exon position, and it is
Mm-hmm.
causing a frame shift mutation.
Yeah.
I believe that it is a premature, almost termination of the protein formation, and still we are
Yeah.
having a milder mutation by having a
Yeah.
termination very early in the coding sequence. How does
Yeah.
this work? Just for my understanding, like how
So,
these kind of very early termination causes a
mm,
milder phenotypes.
yeah, agreed. Even I thought this, but then I saw even exon 8 has been reported to have these milder variants. So I was also thinking what to do. In fact, we had discussed this, that is this again likely pathogenic, but then maybe, should we take it with a pinch of salt? That may not be Alstrom altogether. So very difficult to explain. I don't
Yeah.
have an explanation. Maria, do you have an explanation?
Yeah, so not for ALMS1 gene, but I have seen this in other genes like even retinoblastoma, RB1. You could have an exon 1 or late exon or early exon mutation, and it could be frame shift. But phenotypically, age of onset, nothing changes for the patient. Whether it is a missense mutation or a frame shift or nonsense, it's the phenotype is still very variable, and mostly that happens because that gene alone is not responsible for causing the disease, and there are
Yes,
other
correct.
players, like it could be the driver mutation, but then there could be several other passenger mutations and somatic changes that could be happening that leads to the phenotype.
Okay, so maybe something else is protecting
Yeah.
or
Yeah.
something like that. Mm-hmm.
Mm.
Yeah, that could be one mechanism.
Yeah.
This is also
Thanks, Priya.
Thanks.
This is also seen in neurofibromatosis. I have seen a patient with missense mutation in a much later exon having their full body with neurofibromas, but like a frame
Mm-hmm.
earlier in the exon is not giving such a severe phenotype. So I feel like this scenario is seen in a lot of conditions, but yeah, not always do we have an explanation. Most possible reason they're saying there are other factors which influence the gene, maybe other genes, maybe some intronic regions which are protecting the gene, or like there are factors which genetics we don't understand so well right now.
Yeah, actually, it will be good to have a model where you can actually see how this mutation affects the protein, or maybe in the patient to know the protein levels somehow. I'm just thinking out loud.
Yeah, I think that's a very good idea to check in patient, like functional
Hmm.
assess with
Hmm.
respect to this mutation. That is one very idea. I also liked your point on Dr. Shailaja thinking that it need not be Alstrom and do a deep phenotyping of the retina itself. Like now
Yeah,
we saw the fundus photos, do an ERG, autofluorescence, OCT, everything, and deeply phenotype with respect to the known LCA genes and see if we
yeah,
find any other associations. And also
yeah,
the
could
vision
be.
is like for the retina, what we are seeing and relatively preserved macular area, relatively preserved. The vision is
Hmm.
PLPR, right? It was very low.
Yes, yes, yes. Actually,
It's very low.
actually, Deepika, the photographs are representative photographs because we don't
Oh,
have
okay.
this
It is
patient's
not the
photographs.
patient. Oh, okay.
Yeah,
Sorry,
yeah,
sir.
yeah.
Okay,
So
okay.
I'm also not sure how it looks. So we really have
Yeah.
to check,
Do the
see
deep
the photographs
phenotyping
and
of
all
the
that. Yes,
retina. Yes,
definitely,
yes.
definitely that needs to be done to get an autofluorescence, and maybe the whole macula is gone. It's like atrophic on
Yeah.
autofluorescence. You can
Yeah.
see that.
Okay. Okay. Sorry. Yeah,
Yeah,
I
we
got
didn't have
confused.
the
Sorry.
photograph somehow. I
Sorry.
think because of the nystagmus or something, photograph was not done, and but we'll try with a wider field. We'll if we can get some pictures next time, and we'll post it in the group.
Thank you.
Yeah. Any other questions or comments? I think there's something in the chat box. Okay, Tasneem, you can actually unmute and say it. But she's saying that interesting case scenarios and enjoyed. Thank you. So if there are no further questions or comments, then let's have early dinner then, everybody.